Hey everybody, this is Rusty and welcome to part 3 of 4, Management of Cardiovascular Emergencies. This is a lot of diseases in this presentation, so fasten your seatbelt and put your trays in the upright position and enjoy the presentation. Let's talk about hypertensive emergencies. You know, a normal blood pressure is 120/80. That top number is your systolic function and the bottom number is your diastolic function, or the pressure that's always in your heart. A rapid increase in that diastolic pressure over 130 constitutes an emergency. What causes this? Patients that have a history of hypertension and they don't take their blood pressure meds, those beta blockers, OLALs, or their ACE inhibitors, the PRILs. So hypertensive emergencies, non-compliance with their medications is a big cause. Or there's some toxemia with pregnancy, which is preeclampsia, and the biggest difference between preeclampsia and hypertension and eclampsia is the presence of seizures. So look for those risk factors: age, race, history, and non-compliance of medications. Some chief complaints with our hypertensive patients are headache, dizzy, they could be vomiting, have ringing in the ears, or nosebleeds. We're going to do our primary assessment, that GLT, Z's, A, B, C. Then you look at D's pupils and expose the chest so you can listen to lung and heart sounds. Notice the neck on the way from pupils to the lungs and heart. Listen to 6 heart sounds, or I should say 6 lung sounds and 3 heart tones, and make sure they have pulse, motor, and sensory in all 4 extremities, and squeeze those ankles to assess the presence of pulmonary edema. Initial paramedic care, IV O2 monitor, just like our parrot, and get your past medical history. Look for signs of hypertensive encephalopathy, or that brain swelling, severe headache, nausea, vomiting, visual disturbances, could be even transient blindness in your patient, paralysis, seizure, stupor, coma. Hypertension is defined as a blood pressure greater than 160/90. The patient will have a strong bounding pulse, and look for signs of left ventricular failure, abnormal skin color, pale, cool, diaphoretic, and the presence of edema, pedal edema, JVD. Those are signs you need to be looking for. If that blood pressure is crazy high, over 240, over 120, you can think about labetalol, 10 milligrams slow IV push over 2 minutes. And if it's not helping, you can repeat in 10 minutes at 20 milligrams slow IV push if the BP is still greater than 180/120. You can think about nitro as a second line, 0.4 milligrams sublingual, repeat as needed, up to 3 tabs. If they are having chest pain or you see EKG changes, that nitro is a first-line drug. And then if the blood pressure is still high, you can use some morphine for that vasodilation effect. Next is cardiogenic shock. It's the inability of the heart to meet the demands of the body. It's the most severe form of pump failure, and it comes with a high mortality rate. Various causes are tension pneumothorax, cardiac tamponade, trauma, diastolic or systolic dysfunction, cardiac arrhythmias, and structural problems within the heart. With acute myocardial infarctions, more than 40% of the left ventricular ischemia end up in cardiogenic shock. You can review the clinical symptoms on the picture. All right, and away we go. With your cardiogenic shock assessment, your patients may complain of chest pain or difficulty breathing. They could present unconscious or have an altered mental status. This onset may be acute or progressive over time. They may have a history of recent MI or chest pain episodes. A large anterior infarction, loss of 40% of the left ventricle, can present as cardiogenic shock. Of course, start out with that minimum patient assessment. Get that primary assessment, GLT, A, B, C, D, and E. Check out that neck, and then listen to at least 6 lung sounds, 3 heart tones. Make sure they have pulse, motor, and sensory times 4 extremities, and squeeze those ankles to assess for pedal edema. Look for signs and symptoms of shock. They could be in shock, but there's no trauma. Get your initial paramedic care done, IV O2 monitor, and get that patient history. Beware of mental status changes, that restlessness that progresses to confusion. Watch their breathing. Remember WARF, words per sentence, abnormal sounds or positions. Are they using accessory muscles like retractions, and do they have nasal flaring? Ask them about that paroxysmal nocturnal dyspnea. Do they wake up with that sensation of not being able to breathe? Get that blood pressure. Don't be surprised if they don't have tachycardia or some type of atrial dysrhythmias, because, well, your ventricles aren't working too well. And that BP of systolic less than 80. They are pale, cool, diaphoretic. Look for those signs and symptoms. Treatments for cardiogenic shock. Like I said, that initial care, IV O2 monitor, their O2 sats are going to be low, so supplemental oxygen is required. And you need to identify the underlying cause. If you have those crackles in the backles, you may think about that CPAP and pushing out that fluid so they can pass some gas, that O2 and CO2. If there's no crackles, you may think about some IV fluid. That's based on that Stirling's law. You've got to stretch that muscle so it can contract. You can consider dopamine, 5 to 20 micrograms per kilogram per minute. Remember, it works on both beta 1s and beta 2 properties. Then you can think about dobutamine. It's more of an inotropic, helps that squeeze of that cardiac muscle. Or you can consider norepinephrine, which is that alpha-1 stimulator for that severe vasoconstriction. The American Heart Association has a cardiogenic shock algorithm. You do your assessment, poor perfusion, so it's not trauma related, so think about congestive heart failure or pulmonary edema. Do that basic care, IV O2 monitor, get that baseline set of vital signs, and with your physical finding and history, you determine it's one of these 4 causes of shock: volume loss, vasodilation, pump failure, or abnormal rate. And we'll go through each of these on the next few slides. With shock due to volume loss, you're going to stop all the bleeding and infuse lactated ringers or normal salines, normally 20 cc's per kilo. If it's caused by vasodilation, you're thinking anaphylactic shock or neurogenic shock. Infuse normal saline or lactated ringers and fill up the container. And then consider vasopressors, dopamine or dobutamine, to squeeze down that container. If you're thinking it's an abnormal heart rate, it just depends on how fast or slow it is. If it's over 150 beats a minute, go to the tachycardic algorithm. If it's less than 60, go to the bradycardic algorithm. Cardiogenic shock. If you believe it's due to pump failure, notice the signs and symptoms for acute pulmonary edema. If they have, yes, they have signs and symptoms of pulmonary edema, we're moving to the left side of the screen. Apply the CPAP. Administer nitro sublingual or transdermal. Consider ACE inhibitors, and also consider some benzos for anxiety. After those treatments, if their BP is still less than 100, consider dopamine or dobutamine. If we do the signs and symptoms of acute pulmonary edema, no, well then consider, if their BP is less than 100, consider dopamine or dobutamine. Arthro or arteriosclerosis. Arthro is that progressive degenerative disease of the medium-sized or large arteries. Results in that buildup of fats, cheeseburgers, on the interior wall of the arteries. That fatty buildup results in calcium plaques and can lead to arterio, the thickening or hardening of those vessels. And it can result in claudication or pain in the butt, thighs, or calves from lack of blood flow due to that plaque on the walls. Most common areas for these problems are the carotid arteries, coronary arteries, abdominal aorta, and the popliteal artery behind your knee. Aneurysms, ballooning of the arterial wall, usually in the aorta, that results from weakness or defect in the wall, normally caused by chronic hypertension. Types of aneurysms are atherosclerotic, dissecting aortic aneurysms, and 67% of those happen in the aortic ascending aorta. Infections can cause aneurysms like syphilis. They can be traumatic aortic dissections or a congenital disease called Marfan syndrome, where they're super tall and super skinny and have weak artery walls. Abdominal aortic aneurysm is often a result of atherosclerosis and that hardening of the arteries. Signs and symptoms are abdominal pain, back and flank pain, hypotension, or an urge to defecate. Normally when the patient says that, you don't think about your arteries, you think about GI stuff. But keep that in your brain box. Also might have a pulsating mass around the center line of their abdomen or their belly button. A dissecting aortic aneurysm is caused by that degenerative changes in the smooth muscle and elastic tissue of the blood vessels themselves. Blood gets between those layers and separates the wall of the aorta. It can extend throughout the aorta and into associated vessels. It normally is due to that uncontrolled hypertension. The ABCs of dissecting aneurysms risk factors are that arteriosclerosis or aging aortic aneurysms, blood pressure's high or they're having a baby, and connective tissue disorders, that Marfan syndrome or Ehlers-Danlos syndrome. We've talked about the various causes of aneurysms. Let's do those signs and symptoms, and that just depends on where that aneurysm is. It could be in your head, and the patient will present with headache, dizzy, maybe confused, neurological deficits, possibly like a stroke. So if it's in the abdomen, that abdominal pain, back pain, groin. If it's that ascending aorta, you may get that chest pain. So if it ruptures, if these aneurysms ruptures, it could cause severe blood loss and death. How do we treat it? Pre-hospital environment, we just have the awareness and we go fast to a appropriate facility that can take care of it. The patient needs some blood pressure management, lower their cholesterol. Coiling or stents can be placed in that aneurysm, and they can just clip it off to get rid of it altogether. And then they have to go through regular imaging to make sure it's still working properly. So that's some in-hospital treatment. Pre-hospital, you have to have the index of suspicion and take them to the most appropriate facility. Acute pulmonary embolism is a blockage of the pulmonary artery by a blood clot, air, fat, amniotic fluid, or a catheter shear. The signs and symptoms depend on the size and location of that blockage. So it could be that DVT that in your lower leg that finally broke off and went to your lungs. History: sudden onset difficulty breathing. Patient could have recent surgery, long bone fractures, trains, planes, and automobiles, and long travel. smoking or on birth control pills. They have that difficulty breathing, so you're going to put them on O2. Pulse ox is low. You bolus them with oxygen, 15 liters non-rebreather, and their pulse ox is still low. You're like, that's not right. So think PE. Treatments: blood thinners, anticoagulant treatments, or percutaneous embolectomy. They're going to run that cath in there and retrieve the clot itself in interventional radiology. It's pretty cool stuff. Acute arterial occlusion is sudden occlusion of arterial blood flow due to trauma, a thrombus, tumor, an emboli, or who knows, idiopathic means. It frequently involves the abdomen or the extremities. In the picture on the left, you've got it in the lower extremities. You can see the modeling in that right leg because of the no blood flow. So, vasculitis on the right is inflammation of the blood vessels, commonly stems from rheumatic diseases and syndromes, and you treat the vasculitis with corticosteroids or prednisone. Next is peripheral arterial atherosclerotic disease. It's that progressive disease of the aorta and its branches, cerebral, brachial, and femoral arteries. It can be acute or chronic and is often associated with diabetes. There is pain with exertion, then you rest and it's relieved, but then it starts again. The extremities exhibit pain, coldness to the touch, numbness, and pallor. And that pallor can progress to ulcerations, gangrene, and necrosis. Yummy. Non-critical peripheral vascular conditions. First is deep vein thrombosis, or DVTs. Is a blood clot in the large veins of your thighs or calf. It presents with swelling, pain, and tenderness, and warm red skin. Varicose veins are due to damaged vein walls or broken valves that cause the dilation of those superficial veins and that running back and forth, snake-like pattern. It's common with pregnancy and obese patients. You must remember the 5 P's for peripheral vascular disorders. Those 5 P's are pallor, paresthesia, or those pins and needles sensations, pain, paralysis and not being able to move those extremities, and pulselessness. Radial pulses, posterior tibial pulses, dorsal pulses, those things. Pallor, paresthesia, pain, paralysis, and pulselessness. Of course, do your normal assessment, the primary assessment, GLT, ABC. Look at these pupils, expose these, lungs and heart. Look at the neck for JVD. Listen to 6 lung sounds, 3 heart tones. Check PMS times 4 extremities and pedal edema. Look for signs and symptoms of shock. Look for that pallor, paresthesia, pain, paralysis, and pulselessness. Do your initial paramedic care, IVO2 monitor, and get that patient history. If they have pain with that OPQRST, get that pain scale and give some meds because they shouldn't be in pain. And we are once again at everybody's favorite slide, the end. This is the end of part 3 of 4. Stay tuned for number 4 where we'll wrap up cardiovascular disease treatments.